Welcome to the deep dive. Now, if you're an orthopedic resident gearing up for your final fellowship or FRCS exams, this session is absolutely for you. We know the amount of information on the anterior cruciate ligament, the ACL. It's just vast. So our mission today is really surgical precision. We want to distill those absolute high-yield facts, the controversies you need to know, and yeah, the specific numbers examiners expect.
That's exactly right. I mean, the ACL comes up so often because it really forces you to integrate everything, doesn't it? Basic science, clinical trials, surgical nuance. It's a test of critical thinking. So we're focusing on those key nuggets, the things that let you explain not just what the answer is, but, why it's the consensus.
Absolutely. And look, to keep us laser focused on that postgraduate level, this entire deep dive is grounded in the Ortho Made Simple notes. You can find them on the website mokyingren.sg. These notes are put together by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital in Singapore. He holds his FRCS in orthopedics from Edinburgh, so, he's been through this. Okay, let's unpack this. Starting, I guess, where we always should, the fundamentals, anatomy.
Precisely. Let's start right at the basics. Attachments, blood supply. If an examiner pins you on blood supply, what's the line? And what's the extra bit they want to hear?
Right, so the textbook answer is the middle genicular artery. Easy enough. But the nuance, the bit you have to add, is that the ACL is intra-articular. But crucially, it's extrasynovial. Got to have that distinction.
Perfect. Now the bundles. Everyone talks about two bundles.
Yep, the anteromedial, or AM, and the costerolateral PL bundle, named for their tibial attachments.
And their functions. What does each one primarily resist?
Okay, so the AM bundle, think flexion. It's tight in flexion. And its main job is resisting anterior translation of the tibia. The PL bundle is tight in extension, and that's your primary rotational stabilizer. It resists those twisting forces.
Good. And specific anchor points, where do they actually attach? Precision matters here.
It really does. So femoral side,
Yeah.
it's below the lateral intercondylar ridge. You'll see the lateral bifurcate ridge dividing the footprint there. And then on the tibia, you need to place it medial to the anterior horn of the lateral meniscus, which is posterior to the anterior horn of the medial meniscus. Those relationships are key.
Absolutely key, especially when you're thinking about drilling those tunnels later on. Okay, let's shift gears. Pathology. We all know the classic injury mechanism, that pivoting non-contact injury, often with a valgus force, and the often quoted 4.1 female predominance.
Right. But the clinical distinction, the one that seems to come up again and again in vivas, is the meniscal injury pattern. We hear unhappy triad, but is that really what we see acutely?
Ugh, the unhappy triad. Well, no, not typically in the acute setting. And getting this right is honestly a big differentiator. O'Donoghue's original triad mentioned the medial meniscus, ACL, and MCL. But acutely, it's actually the lateral meniscus tear that's more common.
Okay, so why lateral acutely?
It's that mechanism, the valgus force, maybe some rotation. It compresses the lateral compartment. So the lateral meniscus gets crushed, essentially.
So where does the medial meniscus come into play then? Because we definitely see medial tears with ACL injuries.
We do, but usually later. The medial meniscus becomes the victim in the chronic ACL deficient knee. Think of it like this. Without the ACL doing its job, the medial meniscus becomes a secondary stabilizer. It tries to act as a doorstop to prevent anterior translation. But over time, that repetitive stress, that overload, it just fails. There's good evidence, Mark 2018, for instance, showing that a longer time between injury and surgery significantly increases your risk of finding a medial meniscus tear.
That makes perfect sense. The chronic wear and tear. Okay, and staying with acute injury, what about those telltale signs on imaging, the radiological pearls?
Two you absolutely have to know. First, the second fracture, that little fleck of bone off the lateral tibial plateau, highly suggestive of an ACL tear, and increasingly we associate it with an anterolateral ligament or AL injury too.
Right, the AL is getting more attention now. And the second sign?
The classic bone bruise pattern on MRI. You see it on the anterior aspect of the lateral femoral condyle and the posterior aspect of the lateral tibial plateau. It's the footprint of that impact during the instability event.
Okay, solid foundation. So we understand the injury. Now treatment, given the injury is common, but not everyone ends up unstable. Noyes rule of thirds comes to mind. A third cope, a third adapt, a third don't cope. How do we decide who actually needs an operation?
And that throws us right into probably the single biggest controversy surrounding ACLs. Does reconstruction actually prevent secondary osteoarthritis, or OA? The evidence here is, well, it's messy, perfect exam fodder.
Okay, lay out the conflict for us. What are the opposing findings?
Well, on one hand, you've got studies like Vanny Farren's 20-year follow-up from 2018. They used the older transtibial technique, mind you, but they found no difference in OA rates between the surgically treated group and the non-operative group.
Suggesting maybe the initial injury itself is the main driver for OA, not the instability.
Possibly. But then you look at Sanders' 2016 paper. At 13 years, they found ACL reconstruction patients had significantly lower risks of needing surgery for secondary meniscal tears, lower rates of symptomatic arthritis, and importantly, a lower risk of ending up with a total knee arthroplasty, a TKA.
And haven't some recent meta-analyses even suggested that maybe ACLR itself predisposes you to OA compared to non-surgical management? It feels like you're damned if you do, damned if you don't sometimes?
It can seem that way, which is exactly why that landmark Froebel randomized controlled trial, the one in the New England Journal, is so important. It showed for young, active adults a strategy of really good structured rehab plus the option for a delayed reconstruction later if needed was just as effective clinically as going straight for early surgery plus rehab.
So non-operative management isn't just an alternative, it's a really strong, evidence-based option for the right patient.
Absolutely. You have to be able to discuss that pathway intelligently.
Okay, but let's say surgery is the chosen path. Timing becomes critical. We all worry about arthrofibrosis, that stiff knee post-op. The old rule was wait at least 3 weeks, right? Has that shifted?
It has, somewhat. That 3-week rule came largely from Shelburne's work back in '91, showing really high arthrofibrosis rates if you operated within the first week. But newer evidence suggests that maybe operating within, say, 10 days doesn't necessarily increase that risk compared to waiting the full 3 weeks, provided certain conditions are met.
So if it's not just about the calendar, what's the key clinical guide for the resident trying to decide, do I list this patient next week or hold off?
It's all about the knee state, specifically the range of motion. Forget the clock for a second. The absolute prerequisite is achieving full, quiet range of motion before surgery. Pain-free extension is paramount. There's that great saying, if the knee is not straight, wait. And work by people like Sonnery Cotet backs this up, showing that limited ROM and significant bone bruises are much bigger risk factors for stiffness than just the time elapsed since injury.
That's a really practical pearl.
Okay.
Okay, let's dive into the reconstruction itself, the nuts and bolts. Good question first. Autograft versus allograft, particularly in a young, active patient. What's the exam answer?
Oh, for exams, in that young active population, it's unequivocally autographed. The data is pretty stark. You need to quote the Moon cohort study, Kading 2011. It showed allograft failure rates were significantly higher, over 4 times higher, especially in that really young group, like 10 to 19 years old.
And if you do use allograft, say in an older, lower demand patient or revision setting, any caveats?
Absolutely. You must specify non-irradiated tissue. Irradiation just tanks the biomechanical properties, makes it weaker, less stiff. That's been known since Fiddler's work in '95. Maybe consider some of the newer chemically sterilized grafts, but non-irradiated is key.
Okay, sticky with autografts. Hamstring, bone patellar tendon bone, BPTB, quadriceps tendon. We generally say clinical outcomes are pretty similar, right? But what about the raw strength? How do they stack up biomechanically against the native ACL, which fails around, 2,100 newtons?
Right, native ACL is about 2100 N. The strongest commonly used autograft based on biomechanical testing is the quadruple hamstring graft. That can reach strengths of around 4,000 newtons. It's incredibly strong.
Impressive numbers, but does that extra strength translate clinically?
And that's the crucial follow-up point you have to make. While biomechanically superior in load to failure, large studies and meta-analyses like Danny 2019 or data from the Mars cohort consistently show that the functional outcomes, the patient satisfaction, and perhaps most importantly, the re-tear rates are comparable across BPTB, hamstring, and quad tendon grafts.
So biomechanically stronger doesn't necessarily mean clinically better long-term. An important distinction. Globally, what's the most popular graft choice now?
Hamstring grafts are actually the most common worldwide. The exception is North America, where BPTB still holds a very strong position. That's from recent ISICOS surveys.
Interesting trend. Now, thinking technically during the operation, what's probably the single most critical factor we can control to minimize the risk of revision surgery later?
Graft diameter, no question. You absolutely must remember the magic number, 8 millimeters. Studies show clearly that using a graft diameter of 8 millimeters or greater is associated with the lowest revision rates. If your graft diameter is less than 8 millimeters, the odds ratio for needing a revision jumps up significantly, like 2.2 times higher. That's a number you don't want to forget.
8 millimeters, got it. Okay, tunnel placement technique. For years, transtibial was standard. Why have so many surgeons moved towards transportal drilling, going through the anteromedial portal?
It really boils down to rotational stability. The transtibial technique, because you're drilling the femoral tunnel through the tibial tunnel, inherently forces you into a more vertical femoral tunnel placement. And a vertical graft just doesn't control rotation as well as a more anatomically placed, more oblique graft. The transportal technique allows you to achieve that more anatomic, more horizontal femoral socket. Studies by Ribot, Chalmers, they've shown this leads to better rotational stability and often higher subjective patient scores.
Makes sense. More anatomic equals better function. Now, what about the double bundle, or DB, technique? Freddie Fu really championed this. We know it provides objectively better stability on measures like the KT1000 arthrometer or the pivot shift test. But has that complexity proven worthwhile clinically in the long run?
It seemed promising, and objectively, yes, it often restores stability better on those specific tests. But the overwhelming consensus now, based on numerous meta-analyses, is that DB reconstruction does not offer significant long-term clinical superiority over a well-performed single bundle or SB reconstruction. Patient-reported outcomes, return to sport, failure rates, they end up being very similar. So again, it's that theme. Biomechanically potentially superior, but clinically equivalent in the end for most patients.
Okay, so SB is generally sufficient if done well. What about how we fix the graft in the tunnels? Suspensory fixation like endo buttons, aperture fixation like interference screws, cross-pinning. Does the evidence favor one method?
Concisely, no. The current evidence, including recent large reviews like one by Shixon in 2022, suggests there's no significant difference in major clinical outcomes based solely on the fixation method used. Often, surgeons use a combination, maybe suspensory on the femur, aperture on the tibia, aiming for rigid fixation at both ends. But the ultimate success seems more dependent on graft choice, placement, and tensioning rather than the specific device.
Let's talk about tensioning. Why do we bother pre-tensioning the graft on the back table, sometimes even cycling it? What's the basic science reason?
That's about minimizing two biomechanical phenomena: stress relaxation and creep. When you first implant the graft, it has a certain tension. Stress relaxation is the tendency for that tension to decrease over time, even if the length stays the same. Creep is the tendency for the graft to slowly elongate under a constant load. By pre-tensioning, both statically and sometimes dynamically by cycling it, you're basically preconditioning the graft, trying to get some of that initial relaxation and creep out before you fix it in place. The goal is to ensure it stays taut once implanted for immediate stability.
Okay, clear. And the dreaded viva scenario.
Right.
You drop the graft on the floor. What's the protocol?
Right. Deep breaths first. Then, strict protocol. You need to soak it in 4% chlorhexidine solution for a good 30 minutes. That's the critical disinfecting step. Afterwards, rinse that off thoroughly and then soak it in a triple antibiotic solution, typically containing gentamicin, clindamycin, and polymyxin B. Molina's work back in 2000 showed chlorhexidine was particularly effective, hence it being the primary agent.
Good protocol to have locked away. Okay, shifting to post-op. The graft isn't immediately a ligament. Walk us through the biological stages of graft incorporation, this ligamentization process.
Yeah, it's a slow process. We usually break it down into 3 rough phases. Phase 1, the first, say, 0 to 6 weeks, is the inflammatory stage. This is actually when the graft is at its weakest. There's cell death, some necrosis within the graft tissue. Phase 2, from about 6 weeks to 3 months, is proliferation. Here you start to see revascularization, new blood vessels growing in, and fibroblasts laying down new matrix, mostly type 3 collagen initially. Then phase 3, ligamentization and remodeling, starts after 3 months and can continue for, well, over a year, maybe even longer. This is where the graft structure really matures. The collagen fibers start to organize along the lines of stress, becoming more like the native ACL. It probably reaches its maximum mechanical properties somewhere around the 1-year mark, though remodeling continues.
And for a BPTB graft, how does that bone block actually heal into the bone tunnel? Is it different?
It is a bit different, yeah. It heals more like a fracture. The process is called creeping substitution. It's classic bone heal. Blood vessels grow into the porous cancellous bone of the plug and the tunnel wall. Osteoclasts resorb some old bone, and then osteoblasts follow behind, laying down new bone, integrating the plug directly into the host bone. Remodeling follows via those cutting cones.
So direct bone-to-bone healing.
Okay.
And rehabilitation generally follows these biological stages, right?
Yeah.
What's a typical timeline for return to activity?
Broadly, yes. Early phase, AS 6 weeks, focuses on regaining extension, controlling swelling, quad activation, usually closed chain exercises, weight bearing as tolerated. Then, say, 6 weeks to 3 months, you can often introduce open chain exercises cautiously, start progressing strength. After 3 months, maybe start some light jogging in a straight line if everything's going well. Return to more demanding activities, pivoting sports. That's usually deferred until at least 6 months, often closer to 9 or 12 months, depending on strength, neuromuscular control, and confidence. It's criterion-based, not just time-based.
Makes sense. Finally, complications. What are the most common pitfalls, especially technical ones, that can compromise a reconstruction?
Tunnel malposition is probably number one. Placing the tibial tunnel 2 anterior leads to graft impingement on the roof of the notch when the knee extends. Bad news. Placing the femoral tunnel 2 anterior is also common, especially with transtibial techniques. That results in a graft that feels tight in flexion but gets loose as the knee extends. You need to know those consequences cold. And of course, missing an associated injury is a big one, particularly failing to identify and address a posterolateral corner injury. That leaves residual instability that will eventually overload and stretch out even a perfectly placed ACL graft.
Right, the PLC is crucial. What about that specific cause of extension block, the cyclops lesion?
Ah, yes, the cyclops. It's a localized anterior arthrofibrosis, basically a fibrous nodule, sometimes with cartilage metaplasia, that forms in the anterior part of the intercondylar notch. It physically blocks terminal extension. You see it on MRI, and the treatment is straightforward. Arthroscopic debridement. Shave it out.
Okay, and if you're faced with that dreaded stiff knee postoperatively, what's the systematic workup?
You need a structured approach, what we sometimes call the triple assessment. First, and most importantly, rule out infection. Always. Synovial fluid cell count, culture, inflammatory markers. Second, determine the onset. Was it stiff immediately after surgery? That points towards a technical issue, maybe tunnels, overtensioning, or did it develop later, suggesting true arthrofibrosis or maybe a cyclops lesion. Third, use imaging, usually an MRI, to look for those mechanical causes, tunnel position, impingement, the cyclops lesion itself. And again, double check you didn't miss another injury initially.
And you mentioned missed injuries. What about the meniscus again? What's the consequence if a repairable medial meniscus tear isn't fixed during the ACLR?
It significantly compromises the reconstruction. Remember, we said the medial meniscus acts as a secondary stabilizer, particularly against anterior translation. If you leave a deficient medial meniscus, you're putting much higher stress on your new ACL graft from day one, increasing the risk of it stretching out or failing over time. Repairing repairable menisci is critical for long-term ACL graft survival.
Good point. So overall, what are the realistic outcomes we should be telling patients? Return to sport, long-term graft survival.
Well, return to sport is. It's okay, but maybe not as high as patients expect. Generally, studies show about 50 to 70% of athletes return to their pre-injury level of pivoting sport. Many return to some sport, but maybe not at the same intensity. Long-term graft survival, though, is actually pretty good with modern techniques. Data like Salmon's from 2017 shows survival rates around 86% even out at 20 years. So the grafts themselves tend to last, but functional return is more variable.
Okay, so let's try to summarize the absolute must-knows for the exams. We've hit the meniscal shift, lateral acute, medial chronic. We've tackled the OA debate. Know the conflicting evidence, Van Yperen versus Sanders, and the Froebel non-op option. Technically, that 8mm graft diameter rule is non-negotiable. Know that odds ratio. And be ready to articulate the difference between something being biomechanically superior, like maybe a DB reconstruction or a super strong quad hamstring graft, versus demonstrating actual superior long-term clinical outcomes, which often isn't the case compared to simpler, well-done techniques like SB.
Absolutely nailed it. And maybe a final thought to leave our listeners mulling over. We see good graft survival. 86% at 20 years is great. But return to sport is still iffy, and we have this looming concern about early OA, even with a successful reconstruction. So the provocative question is, where does research need to go next? Is it just about making grafts last longer, or do we need to shift focus towards truly protecting the cartilage, towards optimizing the biomechanics of the entire joint, not just replacing the ligament? That feels like the next frontier. How do we prevent the OA?
That's a perfect point to ponder. Excellent discussion. Thank you for diving deep with us today. And just a reminder for everyone listening, all this high-yield, exam-focused information was drawn from the OrthoMade Simple Notes, which you can find over at mokyingren.sg.
Indeed. We really hope this helps with your preparation. We wish you all the very best in your studies and especially in your upcoming exams. Remember, for the Lord gives wisdom. From his mouth come knowledge and understanding. That's Proverbs 2, verse 6. Good luck.